Dr. Matsuo. As we said, this meeting is a lot about sharing fellows and masters. So we have a younger fellow, Dr. Matsuo, showing beautiful work. And then we have a master on pineal regions here, Dr. Cohen-Garol, showing his expertise afterwards. Dr. Cohen, you want to make any comments?
No, I think I want to thank, first of all, for giving me the opportunity to be here, Juan Carlos, and just mention something about Dr. Rhoton. God bless his soul. You know, he's truly has been such a role model for so many of us. And he has done so much to improve surgery and microsurgery in so many levels. Something that truly was inspiring about him was the passion he had for microneurosurgery and really attention to detail and the outcome, and truly was so dedicated to his patients and their outcomes. And I think that's truly something that all of us are so much inspired by Dr. Rhoton, and we'll remember him for that forever. Also, I want to really take a moment and thank Juan Carlos, who has truly been one of the most loyal and impressive proteges of Dr. Rhoton. And Juan Carlos, you have not only proven yourself to be an incredible master microneurosurgeon, you have proven yourself to be a master neurosurgeon. I think microanatomy is such a small part of your career, even though you have contributed so immensely. I think yourself as a master neurosurgeon have inspired all of us, and I truly appreciate Juan Carlos for putting this together.
Thank you, Ara. Those are very kind words.
You're welcome. And Dr. Matsuo, please go ahead.
Okay, thank you. Can you see my slide?
Yes, sir.
Yep.
Thank you, Chairman. Dr. Fernandez Miranda and all of the members organizing this meeting. Thank you for giving me a chance to give a presentation in this meeting. It's a great honor to be here. Hello, everyone. I'm Satoshi Matsuo from Japan. Today, I'd like to talk about microsurgical anatomy around the pineal region. I have no financial relationships to disclose. Here is the outline of my presentation. First, I'm going to review the basic anatomy around the pineal region. Then, I'm going to show the surgical anatomy of the two common approaches to the pineal region, which are the occipital transtentorial and infratentorial supracerebellar approaches. This is the medial view of the right hemisphere. As you can see in this figure, pineal gland is located almost center of the brain. It is positioned inferior to the splenium, posterior to the third ventricle, above the collicular plate, and anterior to the carmen. This deep region is also referred to as the posterior insular space. Let's get into more detail. This is the enlarged view of the former slide. I'm going to start with the third ventricle. The roof of the third ventricle is formed by the fornix and two layers of the terra colloidea. The terra colloidea attach to the stria medullaris salami. The space between two layers of the terra colloidea is called the vena interpositum. The internal cerebral vein and medial posterior colloidal artery, which is the branch of the PCA, pass through this space. The stria medullaris salami blends into the habenula, and the habenula forms the habenular commissure. It is the upper half of the attachment of the pineal gland to the thalamus. The posterior commissure is the lower one. At the anterior margin of the thalamus, the body of the fornix separates into two columns. The columns of the fornix pass around the superior and anterior margin of the foramen mondo and turn downwards toward the mammillary bodies. The superior and inferior colliculi and the vermis of the lingula and cerebral mesenteric fissure, which was formed by the cerebellum and midbrain, is positioned inferior to the pineal gland. The carmen is located posterior to the pineal gland. It may obstruct surgical access to the pineal gland through the infratentorial approaches. Next, I'm going to review arterial relationships. This is the posterior view of the posterior insular space. tentorium, and cerebellum has been removed. As you can see in this figure, both PCA and SCA, and as well as their branches, courses through the posterior insular space. When approaching to the pineal region through the infratentorial approach, usually the PCA and SCA are less likely to be damaged than the veins, because these arteries do not cross posterior to the pineal gland as do the veins. This figure shows the inferior view of the hemisphere. On the right side, a part of the parahippocampal and the hippocampal gyruses have been removed. The PCA arises at the basilar bifurcation and encircles the midbrain, passing through the crural and the ambient cistern to reach the posterior insular space, and usually bifurcates into its terminal branches, the parieto-occipital and calcarine arteries. The medial posterior choroidal artery usually branches off from the P2 segment. It courses lateral to the pineal gland and enters into the velum interpositum. From the medial side, here we can see the course of the parieto-occipital artery. It courses along the parieto-occipital sulcus. The calcarine artery usually courses inside the calcarine sulcus and sends branches into the inferior cuneus and lingula. The SCA also arises from the basilar artery near its apex, passes below the oculomotor nerve, and encircles the brainstem. As it courses posterior, it passes below the trochlear nerve and above the trigeminal nerve to enter the cerebellomesenteric fissure. After leaving the fissure, the artery gives rise to branches that supply the tentorial surface of the cerebellum. The SCA usually arises as a single trunk, but occasionally arises as duplicate trunks. Now, I'd like to move on to the venous relationships. The venous relationships in the posterior insular space is one of the most complex in the brain because the internal cerebral and the basal veins and many of their tributaries converge in this area. This figure shows the right posterolateral view of the posterior insular space. As you can see in this figure, the vein of Galen and its tributaries passes through the posterior insular space. The vein of Galen courses below the splenium to empty into the straight sinus at the tentorial apex. Among the tributaries of vein of Galen, I'd like to touch on the internal cerebral vein and basal veins. This figure shows the superior view of the lateral ventricles. The body of the fornix, choroid plexus, and terrachoroidea on right side have been removed. The internal cerebral vein originates from just behind the foramen Monroe by the union of anterior septal and thalamostrate vein. Then it passes through the velum interpositum to enter the posterior insular space. Then the vein joins its contralateral one and forms the vein of Galen. This is the superior view of the tentorial incisura. The basal vein is formed below the anterior perforated substance by the union of anterior cerebral and deep cerebral veins. The basal vein courses posteriorly between the midbrain and temporal bone to reach the posterior insular space. Then the vein usually empties into the vein of Galen, but occasionally it empties into the internal cerebral vein. Up to here, I have reviewed the basic anatomy around the pineal region. Now, let me move on to the surgical approaches to the pineal region. The occipital transtentorial and the infratentorial supracerebellar approaches are two most common approaches to the pineal gland. I'd like to begin with the OTA. This is the posterior view of the right occipital and parietal lobe. The surface of the anterior part of the occipital lobe is drained by both posterior parietal and posterior temporal veins. The area around the occipital pole is drained by the occipital vein. They are usually directed forwards rather than medial or backward, so that no large veins around the trochlea. Therefore, usually the occipital lobe can be retracted from the palx and tentorium without sacrificing bridging veins. Retracting the occipital lobe from the palx and tentorium provides access to the ipsilateral splenium above the vein of Galen and to a part of the quadrigeminal system. To expose the lesion inferior to the splenium, dividing the tentorium is required. Dividing the tentorium and dissecting the arachnoid over the quadrigeminal system exposes the pineal gland, the superior and the inferior colliculi, trochlear nerve, and the vein of Galen and its tributaries, including internal occipital, basal, internal cerebral, and superior Birmingham veins. A steep tentorial surface may limit access to the cerebromesencephalic fissure. The internal occipital vein, also known as the anterior calcarine vein, drains medial side of the occipital lobe and particularly calcarine sulcus. Damaging this vein can cause postoperative visual field defect. Approaching from more parietal side or an angled endoscope, as in observing the cerebromesencephalic fissure. Here you can see below the inferior colliculus. This is the superior medullary velum, which is the roof of the fourth ventricle, and the origin of the trochlear nerve is here. Now I'm going to show a case briefly. The patient was a 57-year-old man with multiple metastases. The largest cystic lesion compressed the brainstem and cerebellum, and he manifested ataxia. We planned the partial removal of the cystic tumor through the OTA to relieve the compression to the surrounding tissue before radiation therapy. Besides approaching to the pineal region, the OTA is commonly selected to the lesion involving the tentorial surface close to the brainstem. We usually place the patient in prone position and rotate it toward approach side after dural opening. Placing the patient in prone position and approach from right side. For less experienced surgeon, identifying the venous structures through second arachnoid membrane covering the quadrigeminal system is difficult. To avoid damaging the tributaries of vein of Galen, I usually dissected the arachnoid a little bit far from the quadrigeminal system, such as around the PCA and the pericallosal veins. Here's splenium. This is gonna be pericallosal vein. Before CSF evacuation, great care should be taken when retracting the occipital lobe to avoid damaging the optic radiations. IC green video angiography is helpful to identifying the tentorial sinus and the tributaries of the vein of Galen through second arachnoid membrane. This is PCA and tributaries are here. Dividing the tentorium exposes the quadrigeminal system and tentorial surface of the cerebellum. Dissecting the arachnoid membrane exposes a part of the tumor. Here you can see the pineal gland. After partial removal of the tumor, you can see the inferior colliculus, the origin of the fourth nerve, and part of the supramedullary velum. Here you can see the vein of cerebromesencephalic fissure, also known as the precentral cerebellar vein. To avoid postoperative visual field defect, careful retraction was needed when retracting the occipital lobe. After the operation, his ataxia was improved, and he was referred to other hospital to receive radiation therapy. Postoperative visual field defect is one of the well-known complications after OTA. Understanding the cause of the optic radiations is important to avoid this complication. This figure shows the medial and inferior views of the left brain. Optic radiations has been exposed by fiber dissection technique. The blue area indicates the fiber. After leaving the lateral geniculate body and pulvinar, the optic radiations causes an anterolateral projection and then turn backward. The fibers cover the roof of temporal horn, lateral lobe of the atrium, and the occipital horn, and then reach the calcarean cortex. The optic fibers have anterior, central, and posterior parts defined by the direction the fibers projecting from their origin. Differentiate these three parts with the fiber dissection technique is difficult. MRI tractography can clearly show each part from origin to termination. Both techniques help us understand the cause of the fiber. Now, I'd like to move on to the surgical anatomy of the infratentorial supracerebellar approach. This approach has midline and off-midline routes. The off-midline routes include paramedian, lateral, and far lateral routes. Significant venous trunks obstruct surgical exposure at two levels in this approach. The first is at the level of the vein across the infratentorial space to empty into the tentorial sinuses. The second is that at the level of the quadrigeminal system. This figure shows the suboccipital surface of the cerebellum. The inferior Barmian vein drains the barmis and part of the tonsil. They ascend along the barmospheric fissure and drain into the straight or transverse sinuses or the torcular. Through the midline approach, these veins may need to be retracted or sacrificed to reach the pineal gland. The inferior hemispheric vein originates from suboccipital surface, ascend and cross the margin of the suboccipital and tentorial cerebellar surfaces and drain to the tentorial sinuses. These bridging veins would be less likely to be encountered in the paramedian and far lateral routes than in lateral routes. There is considerable variability in the site of these bridging veins. In the left figure, the inferior hemispheric vein drains a large area of the suboccipital and tentorial surfaces. On the other hand, the inferior Barmian vein drains a large area in the right figure. Dividing the vein, which drains relatively large area, can cause serious complications such as cerebral swelling and hemorrhagic infarction. We should consider the drainage area of veins before dividing them. This figure shows the midline route at the level of the quadrigeminal system. In this route, the superior Barmian vein is aligned with the pineal gland. It may be needed to be retracted or sacrificed to approach to the pineal gland. The steep angle of the culmen limits the exposure around the collicular plate. Strong retraction may be required. This slide shows the off-midline routes. There are several advantages of the off-midline routes. First, as they move further laterally, the angle between the superior Barmian and internal cerebellar veins and provides access to the gland often without venous sacrifice, with the exception of the small tributaries such as pineal and collicular veins. Shifting from midline to off-midline also provides a better view around the collicular plate and the origin of the trochlear nerve than the midline routes. In addition, the off-midline routes requires less retraction of the cerebellum. However, the pulvinar and tentorium can obstruct the surgical exposure in off-midline routes, especially for lateral route. In addition, off-midline routes prevent access to the region extending forward in midline from the pineal gland. Now I'm reaching the end of my presentation. Today, I reviewed the basic anatomy around the pineal region and showed surgical anatomy of the two most common approaches to it. Familiarity with the details of these anatomy is crucial to access to the pineal region. I hope my presentation helps you understand the anatomy. Thank you, Dr. Rhoton. Thank you for your kind attention. Thank you very much.
Thank you so much, Dr. Matsuo. A very revealing and obviously beautiful anatomy
Thank you very
of
much.
the region. Juan Carlos, if I can proceed, is that okay?
Please go ahead, Aaron. As we said before, your contributions, Aaron, to the field of neurosurgery are absolutely remarkable, far-reaching. I know you have in your atlas